Hi Dennis, how are you? This is Mohammed Musa from AFK Study Plan. You know, when you study for AFK, you see the subject, the materials are huge, and then you study some topic, and then you miss some topic, and then you go to restudy stuff again, and suddenly you feel like you are all over the place. Here, when come the question, are critically important. Question get you to know your knowledge, get you to boost your confidence. When you see question and you know how to solve it, you feel like, okay, I'm on a good track now. When you feel like, okay, this concept is not very clear, I need to restudy again, or you feel like this topic is good for me, so I can move to different topics and build my knowledge. Hence, coming this weekly newsletter, which means I'm going to give you one question every day in the website, AFK Study Plan. You go and you see the answers, you pick your correct answer, what you think is correct answer. By the end of the day, I will give you the correct answer with little explanation. And the weekend, I'm going to collect all the questions in one presentation to give you this video. It will cover maybe 5 to 6 questions. Questions are important, but like what's really more important for you to know the concept for every question and to get to know like if this question is going to different location, to different places, if this question is go the other way, I hope you get the correct idea to answer the question in any scenario. With that all being said, let's just start with our first weekly newsletter for AFK. So the system will go as a following. Every question I'm going to tag it according to the topic it's coming from to make it easier for you if you want to restudy again, if you want to dig deep about this question, so you go to textbook and get your complete concept about this one. I'm going to start first with pathology. Is the most beloved topic in for everyone studying for AFK. Question is saying a bluish cyst associated with an erupted tooth of a child is called an, and giving you answers here. Odontogenic keratocyst, eruption hematoma, ameloblastoma, dentigerous cyst. And for this one, I want you to bear with me for a good idea for you. So think about it. I think you know the answer now, but like think about it. You know, while we're young, you know this game when you give you four, three are fruits and one is vegetables, and you wanna pick which one is which. I think you can go with the same concept here for pathology question. When you have no clue about it, you have four option here. Odontogenic keratocyst is inside the bone. Ameloblastoma is inside the bone. Lentigerous cyst is inside the bone. And the question saying bluish cyst. So you cannot say a cyst is blue if it's inside the bone. You cannot say it inside the bone. I think you can know that. So by exclusion, here is eruption hematoma is the answer. I care more for you to get the idea and the concept, how to deal with it. And more importantly, I want you to think about it. Like this one, usually a kid is coming to your office and his parent is worried about this one. Honestly, it looks scary. But as you see the other teeth present in this child mouse, you see like his age between 6 years old, maybe 5, 6 years old, maybe seven max, or maybe 6 years old for this one because other teeth are not here, are not present. Like maybe the permanent centrals lower are present. So this one is good. Like is not really beyond the time for the teeth to erupt. So you don't want to get your child, your patient, to go during a stress of surgery. You use your blade to cut it because I know surgeon here will get mad at me. Like use your blade to cut it. Honestly, this is a stress that you can make your child, your patient, avoid. This is avoidable because like this teeth, when you look in the patient mouse, you see like he's 6 years old, so you can wait for that one. So the key point here is a management for that condition is to let it be. You will not interfere with your sharp blade to open it. It will resolve with time. When you are going to intervene here, if you see the lower laterals here, maybe this one is getting painful, patient is telling you he cannot sleep at night, it's getting more serious, then you intervene. And the idea here, we're trying to minimize the stress for every patient, especially for children coming to our office. So there's a concept, and this is the answer for this one is eruption hematoma. Second question is from Perio. The most appropriate Gracey curette used on the distal side of a tooth number 4-6 is, and then giving you number 7, 8, 9, 7, 8, 9, 10, 11, 12, 13, 14. And this one you should know this information. There's no other way you can guess it. This you should know the information. Gracey curette like is a different set of curette starting from number 1, 2 till number 13, 14, and even goes to 17 and 18. This is, I think this is new for me, honestly. But like usually it go from 1, 2 till 13, 14. And the difference is the angulation. As you can see here in the chart, it giving you the colors and the numbers and telling you which is which. So from 1, 2 is the normal, it's standard. The blade length is the same and the shank design is the same. As you go more and more, the shank design, there's some change to the shank design and even the blade increase or decrease in size. Why? To give you accessibility to reach the tooth in the distal surface of the posterior teeth, medial surface of the posterior teeth. And then as you can see in the chart here, it's a key point here for you to know the numbers, which is using in which surface. So to wrap it up for you, we use 7, 8, 9, 10 for buccal surface. We use 11, 12 for medial surface, 13, 14 for distal surface of the posterior teeth. I don't want you to memorize the answer. I want you to just give yourself 30 seconds to look at the chart and try to memorize it in a way. From the colors, I think you can match it and get the idea to be in your mind. Because like if I go to the question and make it mesial, it will be different answer. If I go for premolars, it will be different answer. If I go to anteriors, for sure, it will be different answer. So I want you to know the Gracey curette as a set and which number is used to treat which surface of every tooth. Okay, that is for this question. So the answer here would be 13, 14 as a question saying is the distal side of 4-6, which is a posterior molar. Third question is from Perio again. Management of an enamel pearl at the buccolingual forcation of an upper second molar with deep pockets includes which of the following? So the question here, and I want you to follow this idea when you're solving the question. You don't read the question and jump to option. I want you to read the question, think about it, think about the possible answer, and try to decipher the information. So he's asking you about the management of a condition. This condition he explained to you is in the upper second molar leading to deep pockets includes. So you have now deep pockets for a patient and he's asking you about the management. So he gives you 4 options. 3 months of periodic scaling and root planning, raising a flap and remove the pill, no intervention or extraction. So you think here from the question, the scenario you have, and I know this is sad because AFK used to be like fundamental. Now he's giving you more clinical scenario question, but like it is what it is. You should know how to tackle this question and know how to answer it. And I don't want you to be intimidated when you see a long question or clinical scenario question. You are a dentist. I want you to bear this in mind. You are a dentist. You are not to be a dentist again. You are a dentist. You are trying just to get a certificate here. So with your clinical judgment, if this patient has deep pockets, so you should intervene. So let's exclude no intervention. And then extraction, I will not extract a tooth with deep pocket unless it's vertical root fracture. It's a different scenario with tooth with RCT treatment and post and core. Patient feel pain while biting. It's different scenario at all. And 3 months of periodic scaling and root planning, it will not fix it. It's a deep pocket. So I think the correct answer here is to raise a flap and remove the pill. Why is that? As you see in this picture here, enamel pill is enamel in a wrong position, in a wrong location. So you see here a root surface with enamel getting out of it. So the problem here is enamel cannot be attached to BDL. Enamel cannot be attached to BDL. BDL can attach to only cementum. So at this location, BDL are trying to invest from the interdental bone to the root and then is faced with enamel, which is for the BDL is a foreign body. It cannot attach to it. So at this area, you will see a very deep pocket. Whatever the patient is doing, whatever you are doing, this will not solve the problem because there is mechanical locking, preventing the BDL from doing its job and to make the pocket less deep. So the key word here is a deep pocket, meaning there is a strong reason for you to intervene and do a small surgery to correct the condition. 3 months of periodic scaling will not correct it, as will not correct this option, will not correct this condition. Is a correct option if the question didn't mention a deep pocket. Of the question, the same scenario, but like he's saying there is no deep pocket and there's enamel pearl, you take X-ray and you see enamel pearl and you go probing, it's good. So meaning this enamel pearl, maybe it's a small enamel pearl. Maybe this enamel pearl is going from different side, does not interfere with BDL attached to the cementum. So you let it be, you don't intervene. So the idea of surgical intervention is to solve a problem that cannot be solved by other way. Other than that, you just do recall, periodic looking at it, you take X-ray and follow up. Okay, so for this one, the answer is raising a flap and remove the flap. We're gonna speak about endo question. As you were performing root canal therapy on a maxillary first molar, and during your search for MP2, like mesiobuccal 2, you perforate in the forcation area. Which of the following is the most significant determinant of prognosis? So again, I want to decipher the question. So you are doing root canal and you're doing access, and you are a very good dentist, so you are trying to give excellent treatment, so you were looking for MP2. While you were looking for your bad luck, it was a bad day for you, you perforate in the forcation area. So the question specifically mentions the location. So he told you it's in the forcation area. Which of the following is the most significant determination of prognosis? So he's telling you you are going to fill it, you are going to close the gap, the perforation you did here. So what is the most important? Time until perforation is repaired, size, or location. So location is observed here because like he told you, it's a forcation area. So you think about size and time. When you go to textbook, it's speaking about perforation in a different concept. But the conclusion here, it has been recognized that the treatment success depends mainly on the immediate sealing of the perforation and appropriate infection control. And here come very simple biological answer here. So size is important. I cannot disagree when you're telling me size is important. But again, I want you to decipher the question. He's asking which of the following is the most significant determinant of prognosis. So prognosis mean like the success of the treatment you are going to give to your patient. So size is important, but like if it is small in size and you missed it and the patient goes home and come back to you, and while you try to locate other canals, you found the perforation and it's a small perforation and you close it. The prognosis here will be poor. It's small, yet I know, but like you left it open a long time. So here, the critical point here is the timing. If you close it very fast, if you close it with effective material in a good technique, and you didn't let infection go inside the bone from the outside, so you are good here. Most likely you are going to have a good prognosis, and the vice versa. If you let it to wait for a long time, if you let the patient go home and come back, you let infection go here, the prognosis will be less. So I know some of you will think, okay, I know your answer is correct when you're saying about the location. Location is the most important, and I know if you go in any textbook, the perforation and prognosis depend mainly, first of all, at the location. If it's in crystal, it will have a poor prognosis. If you go coronal, it will have good prognosis. If you go apical, it will have a good prognosis. So the crystal one is the worst prognosis. I know that, and you can see it in textbook. But in this question, again, it's a clinical scenario. You should navigate the scenario and decipher the information. He will never give you any information just like for his leisure or for your to waste your time. Any information you see in the exam is for you to read it, decipher it, and get more information about it. And as we said before, as the question said, it's floor perforation done while trying to find MP2. So location here is no significance. Like you know it's in the floor, so you don't say it. Location is important here. So time until perforation is repaired is the most critical point. Then go to patho again. Commonly used medication to manage trigeminal neuralgia include, and this question you can say patho and pharma in the same way. Maybe I will change it to make it pharma, honestly. It's more like pharma question. Amitriptyline, carbamazepine, glycerol, propranolol. So for any pharma question, you should have this rule. When you read the question, you're trying to get which medication, which condition we're speaking about, and then when you go to the answer, You try to go, okay, this medication is used to this one, this one, this one. You go by exclusion, you will find your answer very easy. Or the other way, if you have good knowledge about the pharma drug, you will just pick the answer right away. So think about it differently. Amitriptyline, this drug is used for atypical facial pain. It's not trigeminal neuralgia. What's the difference? Atypical facial pain, trigeminal neuralgia, is a very painful condition. It's triggered by touching or shaving your, maybe putting some makeup for females. It triggered very sharp and stinging pain. But atypical facial pain is pain with no cause, like your patient coming to you telling, I feel pain here. It's a vague, dull pain going everywhere. So you are trying to give him amitriptyline. It's like anti-inflammatory medication at the basic pharmacology. You're trying to control the pain here. But carbamazepine, they found it. It's very useful to treat this condition. I'm going to explain trigeminal neuralgia more. And then glycerol. Honestly, I don't know this medication. And then propranolol. Propranolol, this all ending is beta blockers used to treat hypertension. So by exclusion, I don't know about C, so I will ignore it. And I want you to not to be intimidated when you see option you don't know about it. You try to navigate other option and to get to the correct answer. So let's speak about the trigeminal neuralgia. Trigeminal neuralgia is a rare but painful disorder that affect about 1 in every 15,000 people. So you might see it in your office. I saw it twice and honestly it's nightmare. TN patients suffer episodes of stabbing, electrical shock-like pain in the eyes, lip, nose, scalp, forehead, and jaw. When with the distribution, I think you can know which side is affected. It's because the trigeminal nerve is affected here. The pain originates from trigeminal, fifth cranial nerve, responsible for providing sensation to the face. The most common cause is thought to be compression of the nerve root by a blood vessel, and they don't know exactly what's the problem, but this is a finding they most commonly found when they do more investigation for these patients. Because pain is often first experienced along the jaw, trigeminal neuralgia is frequently mistaken as a dental problem. And this patient is coming to your office because he thinks pain is here, so I'll go to dentist. I'm not going to my medical doctor. Trigeminal neuralgia is more common in women, and patients are typically middle-aged or seniors. The unpredictable severe pain from trigeminal neuralgia is emotionally anticipating and may significantly impact quality of life. Think about old lady, like when she's trying to do any makeup and she's touching this point, like it's sharp lancinating pain. They describe it as sharp lancinating pain. So it's horrible. It's honestly it's very painful. It's a nightmare for you and your patient. The pain can be triggered when cold air touches a specific facial area or with movement like chewing, talking, smiling, or swallowing. So this condition is serious, you should intervene. Because pain is often experienced along the jaw, we said this before, so it's severe pain and this is how we deal with it. So the first line, we go carbamazepine or oxa oxacarabazepine. It's a different name from the same category. And then you can add more piclofen. Piclofen is like, it's not NSAIDs, but like it's the same family. Or you can use surgery to treat it, or alternative medication is pregabalin, gabapentin, valproate acid. So this medication is correct answer also. So if I give the same question and I remove carbamazepine and giving you pregabalin or gabapentin is the correct answer. If you don't see carbamazepine, pregabalin, gabapentin, amitriptyline is not a very good answer, but it could be an answer. But for sure, the first line here is carbamazepine and its family, or pregabalin, gabapentin, or valproate. Okay, I hope this is clear for you, and they will adjust it to make it pharma because honestly, this is a pharma question. This is not a pathology question. So the answer here is carbamazepine. Okay, and hence come the last question, and it's pharma question, and it's a very interesting question. I would like you to pay attention here. So, which of the following is an indication of a steroid cover? And he giving you 4 scenarios. So I would like, before we go to the 4th scenario, to know which patient will require this condition of steroid coverage, and then we go to read the scenarios again. So we have 3 rules for patient to for us to say, okay, this patient will need to get some steroid coverage. First of all, to undergo stressful procedure. I want my patient is not coming to do scaling, is not coming to do simple fillings. He's going to stressful procedure, which at least make extraction. Second, patient is take physiological dose for 2 weeks at least. is not taking physiological dose like 2 3 days, no, at least for 2 weeks. Last 2 weeks he's doing it. And there is one risk factor, at least from the following one: pain, infection, poor health, or long term steroids. So when I have one, two, three, or one patient, so I say, okay, this patient is eligible, is qualified to get the medication for steroid coverage. And then we are going to speak about different criteria. Before we dig deep in this, we need to know which patient will require this steroid coverage. So I don't want to waste your time here, but like there is adrenal insufficiency problem. It's coming from not enough corticosteroids is secreted in your patient body because he has a problem. It's not our topic to speak about it today, but in the bottom line here, like speak like about Addison disease. So normal patient have physiological output of adrenal cortex, usually about 20 to 25 milligram of hydrocortisone. I would like you to pay attention to the name hydrocortisone or cortisone. It's between 20 and 25, and you will know why later because the name is important. So normal patient, he will have between 20 to 25 milligram per day of hydrocortisone or cortisone. What happened with this Addison patient? We are giving him medication. So we are giving him some exogenous steroids to restore his level of steroid. So patients also are encouraged to ingest adequate sodium and to monitor their blood pressure to get away from the stress. And this also because like stress and trauma and episode of during episode of illness, it induce more. In this time, this patient, if it's your patient is going to stress, is going trauma, is going to different stuff, so the dose level usually for normal patient, it will increase from 25 to 20 to 75. So for a normal patient, his body is secreting every day 20 to 25. If he goes stress, if he go infection, if he go trauma, this number will raise to be 75. And this is happening for minor surgery. And this number go to 100 or 150 for the major surgery. So we're speaking about the normal patient. Normal patient, if he goes stress, minor surgery, moderate surgery, raise from 25 to 75. If you go major surgery, it will go for 100 or 150 the same day and the following day after this one. So this is the physiology for normal patient. So for our patient here, he need coverage from our side because he need it. He cannot secrete it. So surgery cause increased plasma corticosteroid level during and after procedure. Plasma cortisol level peak at 2 to 10 folds above the baseline between 4 to 10 hours after the operation. The level of response is based on the magnitude of the surgery and whether central anesthesia is used. Postoperative pain is also contributory to elevated cortisol requirements. And then Khaled, like this is the name of the reference, and other estimate that adults secrete 75 to 200 milligram per day in response to major surgery and 50 during minor procedure. Cortisol level usually return to baseline within 24 to 48 hours. Why I read this for you? Because when you see numbers here now, I think it makes sense for you. So not every patient with adrenal insufficiency is qualified for this. It's only primary adrenal insufficiency. If it's a secondary, as you see in the table, very obvious, he's not eligible for this one. So pay attention to the question. If question saying he's secondary, so he's not eligible, even if you go for major surgery. So routine dentistry for primary, none. Minor surgery, we're giving him 25 milligram of hydrocortisone equivalent. I will tell you what the meaning of equivalent now. If you're going to moderate surgical stress, 50 to 75 milligram day of surgery and 1 day after the surgery, and he returned to the normal after this day. If you go major surgery, 100 to 150 the day, and given the 2 to 3 days after the surgery, and he goes after that to the normal level that he used to get. The guideline based on patient's adrenal insufficiency status, however, requirement could increase if the patient health is poor, if concurrent fear or anxiety, infection that is poorly managed, fever, cirrhosis is present, or major surgery with general anesthesia. So let's go back to the first slide. We speak about numbers and names. So we said it's three rules. It's three steps. So patient coming to you, he has adrenal insufficiency. You check first the procedure. Is it stressful or not? Second, is he taking this medication for at least 2 weeks with the physiological dose? If he's taking less than physiological dose, so he's not qualified unless he has one from the following four. One risk factor at least, which is pain, infection, poor health, and long-term steroids. So why I keep saying hydrocortisone? So they have different types of cortisone available in the market. So starting from hydrocortisone, ending with the potent one is dexamethasone. So when we say the patient, usually he has the physiological dose is 20 hydrocortisone. So you see the last line, prednisone 5 is equivalent to 4 of prednisolone and 20 of hydrocortisone and 0.75 of dexamethasone. So every 20, so the physiological dose of hydrocortisone is 20, equal to 7.75 of dexamethasone, and equal to 4 of prednisone and prednisolone and 5 of prednisone. So when you read the question, you should know which number means which medication. So you don't read like just 4 or 5 or 20. You should memorize these numbers and get your equation so you know what number is the correct number, and then you can reach the answer very easily. So let's now read the question. I think it will be super easy for you now to get the answer. Oh, sorry. So, patient will be undergoing extensive restoration procedure on his upper left quadrant and has been taking 20 milligram of hydrocortisone daily for the 20 years. So, first of all, the procedure is not extensive restoration, so he's not qualified. But let's just read it. So, has been taking 20 milligram of hydrocortisone, which means he's taking a physiological dose for 20 years. So he's eligible for the second and third, but the first one is not eligible. So this one is not eligible for a steroid coverage. Patient will undergo surgical extraction. So procedure is qualified. Of severe decayed tooth and has been taking 10 milligram of hydrocortisone daily for the past 10 years. So again, this question is saying 10 milligram of hydrocortisone for past 10 years. 10 is less than the physiological dose for 10 years. Third scenario, patient will undergo surgical debridement and had been taking 5 milligram of prednisone up to until a month previously. So this patient is not qualified at all because like for the last 2 weeks, he's not taking the medication. He will go surgical debridement, but he's not anymore. So this one is not qualified for. So A and C is not qualified. So let's check D and compare it with B. D. A patient who will undergo extraction, so procedure is qualified, of a tooth with vertical root fracture, so pain is present, maybe infection is present, and has been on 5 milligram of prednisone daily for the past 5 years. So he's taking 5, which is equivalent to the physiological dose for the past 5 years. So this patient has all criteria. He will undergo extraction, and the vertical root fracture means the pain is here, infection is here, and he has taken 5 milligram of prednisone for the past 5 years. So this patient is totally qualified to get the medication. If you go to a patient in option B, is taking 10 milligram of hydrocortisone, which means it's less than physiological dose. So this patient, he's going to do surgical extraction and he's taking the medication for 10 years, but he missed one qualifying criteria. So this patient is not qualified to take the medication. I hope this is clear for you. I don't want just to give you the answer. I give you the concept. Here is the reference. You can read at your convenience. I will provide you with a PDF here. You can download it. You can share the video with your friends taking the exam or studying for the exam. And for sure, feel free to give me your feedback about the everything in this newsletter. It's like a new idea from my side just to, I know dentists, when they're studying, they are like focusing on study, and they lose the attention to read question and solve question. And I meant the question to be long and clinical scenario for you to get the answer and the concept. I don't care about the answer. I care about you getting the concept. Feel free to give me any feedback and ask more questions. I will be really happy to help you. And as usual, have a good day.